Good evening, everybody, and welcome to CCI EBUS Webinar Series Part 4. The title of today's webinar is From Planning to Precision, Improving Yield of Endobronchial Ultrasound. At the outset, I'd like to thank CCI for giving us this opportunity to conduct this webinar. Today, we have four eminent pulmonologists with us. Dr. Supreet Batra from Chennai, Dr. Bala Raju Tadikonde from Visakhapatnam, Dr. Vrushali Khirid from Pune, Dr. Pravin Taware from Mumbai, and we have Dr. Sharada Nagoti. She is a senior pulmonary pathologist from Mumbai. So welcome you all. And today's session, I'll be moderating myself, Dr. Sushil Jain. I'm from Raipur. Today, we'll have three short lectures. This will be followed by a panel discussion. The three lectures will be, the first one is pre-procedure planning of EBUS, which will be from Dr. Pravin Taware. The second one will be optimizing EBUS strategies to improve the diagnostic yield by myself, Dr. Sushil Jain. And the third one will be rows and handling of tissue, pathologist perspective by Dr. Sharada Nagoti. So we'll start the three lectures one by one, and this will be followed by panel discussion. Can we start the lectures, please?
Good evening, everyone. Before we dive into the discussion, I want to extend my sincere thanks to CCI, Krishna sir, for the kind invitation to this EBUS webinar. A huge thank you to course coordinators, Dr. Ravi Doshi sir and Dr. Jaykumar Mehta sir. Today, I got chance to discuss pre-procedure planning for EBUS. So one of the Chinese philosopher, Kong Fuji quoted, success depends upon previous preparation, and without such preparation, there is sure to be failure. So before every procedure, you need to prepare things and keep the things ready. So before every procedure, you should be having some checklist like that. Before EBUS procedure, you should have all the investigations ready, like bleeding time, clotting time, PT-INR, platelet count. You should have good recent imaging, contrast CT scan to localize the nodules and lymph nodes. Prior informed written consent is very important, and you should give adequate time to the patient before signing the consent. A good IV access before moving to the endoscopy room is mandatory, and don't put the IV line in endoscopy room. It should be before moving to the endoscopy room. Reconfirm, ensure the indication of the procedure, why we are doing the procedure. Always discuss regarding type of anesthesia in advance with the anesthesiologist. So the most important step is choosing the patient, and choosing the right patient is very important. So most commonly indications will be for the diagnosis of mediastinal adenopathy, central masses, and mediastinal staging like lung cancer. So most common differential diagnosis of mediastinal adenopathy in our center is like tuberculosis, adenocarcinoma, sarcoid, lymphoma. Thorough evaluation prior considering EBUS is very much important, and if an easier accessible site is available, try sampling that site first, and also assess the fitness of the patient for the bronchoscopic procedure in advance. You should know when not to do the procedure, so you should know the contraindications, which is very important. Any contraindication for bronchoscopy, you should avoid EBUS. Hypoxemia that can't be optimized. Absent consent, if patient hasn't given any consent, don't proceed with the EBUS procedure. Unstable cardiac status and hemodynamics, and untrained operator. If you are not trained in EBUS enough, don't do the procedure. Reviewing the radiology scans prior to the procedure is very important. Always check previous scans. Discuss with radiologist if you have any doubt. If possible, review all the scans in the form of videos in console and decide the lymph node station before doing the EBUS procedure and identify the lymph node characteristics, and you can jot down the differential diagnosis depending on those lymph node characteristic for your pre-test and post-test diagnosis. So pre-procedure evaluation starts from checking the detailed history, checking the drug history, and if you have seen aspirin and clopidogrel in their drug history, you can continue prior to the procedure if risk of thrombosis is not very high. Discontinue anticoagulant when you have variable duration of discontinuation before the procedure. Like warfarin, we discontinue warfarin for 5 to 7 days before the procedure. Coagulation profile and platelet count may be performed in patients at high risk of bleeding, and you don't need any prophylactic antibiotic. It is not recommended as per guidelines. Precautions when patients on blood thinners, specifically clopidogrel. In special situations, you should avoid giving clopidogrel peri-procedure, like if you are doing a transvascular, transpulmonary artery or transaortic lymph node biopsies, or EBUS guided transbronchus mediastinal cryobiopsy. Keep all the accessories ready before going for the procedure. Keep your EBUS needle ready, normal saline, formalin for collecting the samples, lignocaine, all the specicans should be ready, vacuum syringe which you require for EBUS sampling, and gloves. So here you should do equipment preparation beforehand. So putting a balloon over the transducer of the EBUS is very much important, because once you start the procedure, you won't get time to put the balloon again. So if you are targeting smaller lymph nodes like 4L, or difficult lymph nodes like 10L or 10R or 11R, you should do this balloon attachment before the procedure itself. And always do a needle preparation also before the procedure. Checking the needle is very much important for your convenience and reduce the time during the procedure. Pre-measurement of the needle and fixing the needle in order to see only tip of the sheath at 1 or 2 o'clock position, as you can see in the video. Knowing EBUS is very important. As a IP guy, you should be knowing all the new EBUS scopes and what are the characteristics of the scope. Like this is the new EBUS scope BF UC 190, which has a 20-degree forward oblique view, as compared to previous model which was 180F, which has a 35-degree oblique view. The tip is extended beyond the lens. Outer diameter and inner diameter you should know, so that you know which number needle you can use and which patients you can use these bronchoscopes. And obviously you should know the importance of the balloon and how to use the balloon. Anesthesia you should discuss prior doing the EBUS procedure. If patient is requiring whether deep sedation along with ET tube intubation or LMA, agents will vary with anesthetist, but propofol is widely used. If you are using moderate sedation along with local anesthesia use infiltration, good infiltration in the throat or vocal cord. As you go in, you can spray, or transtracheal or cricothyroid injection of lignocaine you can use for better local anesthesia. And midazolam and fentanyl is the most common cocktail we use in our practice. So EBUS can be done under conscious sedation or general anesthesia. We do under moderate sedation most of the time, and sometimes general anesthesia with the iGel as an artificial conduit. If you are doing it for a therapeutic purpose, or if you are doing for the staging of lung cancer purpose. If you know the procedure will be prolonged, then you can use as anesthesia. May need multiple modalities like ET tube or LMA. Post-procedure monitoring is very important when you use general anesthesia. You may need more local anesthesia if your procedure is prolonged, and transtracheal instillation is always beneficial. So before going with EBUS procedure, you should be knowing EBUS lymph node features like central necrosis or loss of hilar properties of the lymph node. EBUS features have potential to help in more precise location of a malignant lymph node, thereby helping in increasing diagnostic yield. However, there is no single sign which is diagnostic. This information is supplementary to the tissue diagnosis and can't replace the need of tissue sampling. Patient preparation is very much important along with the equipment preparation. NBM status is important at least 4 hours after liquid and 6 to 8 hours after the meal. A solid diet, you can do EBUS procedure. Pre-procedural lignocaine nebulization 3 to 5 ml, 2% lignocaine you should give at least 10 minutes prior to the procedure, and bronchodilator nebulization if patient is having underlying COPD and asthma. Monitoring, all these monitoring equipment should be ready prior the procedure itself, like oxygen you should attach, saturation and NIBP monitoring and ECG monitoring, especially in patients with history of cardiac disease. So what are the prerequisites for EBUS? Choosing the right patient, pre-procedural evaluation of the patient, discontinuing antiplatelets and anticoagulants if thrombosis risk is not that high. Blood parameters checking is very much important. Coagulation profile, platelet count and OT serology. Chest imaging, you should check chest imaging prior and make the 3D mental reconstruction. Patient preparation, as we mentioned, NBM status and optimization of underlying chronic lung disease. Informed written consent, if possible audio-visual recording, and instrument preparation like balloon application, needle preparation, and fixing the needle sheath in the scope. Teamwork all the way is very important. Without team support, you cannot do EBUS and you cannot have good diagnostic yield of EBUS. So technician and nurse support is vital. Thank you very much.
Good evening, everyone. At the outset, I'd like to thank CCI for giving me this opportunity to give this presentation today. My topic for the day is optimizing EBUS, strategies to improve the diagnostic yield. Why this topic is important and why it matters? EBUS TBNA is central to lung cancer diagnosis and staging in mediastinal lymphadenopathy evaluation. So these are the two most important things for which EBUS is used today. It has been reported to have a diagnostic yield between 60 to 95%. So there is a huge range here. And the reason for it is that if you don't do the procedure well, your diagnostic yield may be as low as 60%, while if you do the procedure well, your diagnostic yield can be reached as high as 95%. So the yield depends more on technique than technology. So the key message here is a perfect scope does not compensate for imperfect sampling. So that's very important for all of us to understand. So you need to do the procedure very well to get a good diagnostic yield. What do you mean by definition of diagnostic yield? If the proportion of procedures providing adequate tissue and giving you a definitive diagnosis defines your diagnostic yield. This includes ability to perform cytology, histopathology, ISC and molecular testing, and tissue cultures. So if your procedure is giving you accurate tissue diagnosis, then the yield is good. So that's what we need to see, that our procedure gives you a final diagnosis. Now, determinants of EBUS diagnostic yield. There are 5 pillars to give you a good diagnostic yield: patient and node selection, imaging and procedural planning, sampling technique, specimen handling, and operator expertise and MDT support. So these are the 5 pillars which determines how the diagnostic yield of EBUS would be. Now coming to patient selection. We all know that if we select the patient correctly, we will be able to have a better diagnosis. And for a higher yield, we need to select those patients who have enlarged lymph nodes, that is more than 10 millimeter in short axis. PET positive lymph nodes also give a higher yield, and the lower yield is usually seen with smaller or necrotic nodes. So the clinical suspicion should guide the aggressiveness of the sampling. Then comes the pre-procedure imaging. Again, a very important step before we go ahead and perform our EBUS. We should mandatorily review the CT scan or the PET CT scan, whatever is available with us, identify the target nodal stations, and look at the size, necrosis, and vascular proximity of that lymph node. and then a planned systematic staging, that is N3, then N2, and then the N1 lymph nodes. So this is the way we should proceed, and a proper case selection and pre-procedure imaging evaluation makes a procedure much better than if you don't do it well. Then comes the lymph node ultrasound features. This is again a very important thing to remember. Features associated with a higher yield are a rounded shaped lymph node, distinct margins, heterogeneous echo texture, and absence of central necrosis. If we find the lymph node with these features, then the chances of success are much higher in these lymph nodes. Coming to equipment optimization. Again, a very, very important thing which you need to understand, that when you do a procedure, you should have correct scope positioning, needle selection. Again, we need to understand that we may use a 21 gauge or 22 gauge needle. Both can give almost similar diagnostic yield. However, 21 gauge gives some better tissue core, whereas 22 gauge, it gives a more easy maneuverability is there. So you need to select according to the individual requirement in a particular case. 19 gauge needles may provide superior results for subclassifying lymphomas and certain benign diseases, though sample may be more bloodier. So occasional situations, we may have to use the 19 gauge needle. Now, before we start, we should check needle integrity, suction system, and the Doppler. So we need to make sure these are functioning properly before we start the procedure. Now, coming to advanced equipments and adjuvants, there are certain situations where we need more advanced equipments and technologies which may help you to get a better tissue diagnosis. This includes EBUS guided forceps biopsy. There are studies which have suggested that supplementing TBNA with mini forceps significantly improve yield for sarcoidosis, from 58% to 93%, and for lymphomas from 30% to 86%. So EBUS guided forceps biopsies may be useful in selected subset of patients, especially if your initial EBUS TBNA is negative, or when you are doing a ROSE and your initial TBNA doesn't give an answer, you may proceed with a EBUS guided forceps biopsy. Another important tool in this is the cryobiopsy. EBUS guided cryobiopsy offers higher sensitivity for rare tumors and benign disorders compared to standard TBNA. Also, EBUS cryobiopsy may be used in cases where you are not able to get adequate tissue with your standard EBUS TBNA. Then you may consider for a EBUS guided cryobiopsy in these cases. Then comes the scope positioning and stability. In-phase contact with airway wall is very, very essential when you're doing an EBUS TBNA. If your contact with the airway wall is not good, then you will not be able to get appropriate image and you will not be able to get a good tissue. We also should have adequate balloon inflation if you're using the balloon. A lot of people don't use balloon. Then in case you're not using the balloon, make sure that the EBUS scope tip is in close contact with your airway wall. And stable scope would give accurate needle targeting. And if there is instability, then you can get a false negative on report. So make sure that your positioning of the scope and the stability of your scope is properly done. Then comes ultrasound and Doppler use. Confirm nodal stations before puncturing, and use Doppler routinely to avoid vascular structures, reduce bleeding, and blood contamination. Always visualize needle tip in real time. Make sure you are able to see your needle tip in real time while doing the procedure. Coming to needle insertion technique. This is also a very important step to get a good tissue diagnosis. A single decisive puncture is what you need to do. Visualize needle tip inside the node, avoid cartilage and calcified areas, and maintain constant ultrasound guidance. You make sure that your needle is always seen throughout the procedure and you are visually seeing that the needle which going inside the lymph node. So that's a very, very important step in getting an accurate diagnosis. Coming to the techniques, there are a couple of techniques which have been described which can help you to improve the yield. The two techniques which are commonly used are jabbing technique and fanning technique. Coming to jabbing technique, we do about 10 to 20 rapid to and fro movements. Needle tip remains within the node. Maintain constant ultrasound guidance throughout the procedure, and this enhances the cellular yield. So jabbing technique is most common technique we use in our clinical practice. The other technique which is used is the fanning technique. In this, we change the needle trajectory within the same node. We sample multiple areas, including central, peripheral, and different quadrants. It improves the representativeness and the yield of the procedure. So this technique is very often utilized by people who have been doing EBUS, and this technique helps to get a better diagnostic yield. Coming to suction strategy. Now, suction, there are different school of thoughts. Different people use different strategies for suctions. Some people don't use suction at all. They use the capillary technique, then low suction, that is between 5 to 10 ml, or a standard suction, which is usually 20 ml. Now, excessive suction can cause bloody samples. Tailor suction to node vascularity. Use minimum suction when possible. Release the suction before withdrawing needle. and avoid vascular areas using Doppler. Now, though different suction techniques have not shown any additional benefit in clinical trials, however, most of us use suction during EBUS TBNA. However, even if you don't use the suction, your diagnostic yield doesn't change much in majority of patients. Coming to number of needle passes, again, very important thing to remember. A minimum of 3 passes per lymph node is essential to get a good diagnostic yield. Increase the passes when there is no rows. If you are planning to do molecular testing, if that's required, then definitely you need to have more passes, so to have a better tissue. If you are suspecting lymphomas or sarcoidosis, then the number of passes need to be more. And if you need a tissue gene expert or AFB culture or other cultures, then you need to have more tissue and you need to do more passes. So these are the indications when you have to consider for more than 3 passes of a particular lymph node. Then sampling multiple nodes. Again, very important that they follow systematic staging order. If you're suspecting malignancy, label specimen by nodal station. This will prevent cross-contamination and staging errors. Specimen handling. Now, about specimen handling, we'll have another lecture after me, but let me just give a brief about it. That when you are preparing the sample, make sure that the prepare smears immediately. Always create a cell block. Send gene expert and cultures when indicated. Minimize blood contamination and preserve tissue for ISC and molecular testing. So you need to handle the tissue well. If you have taken a sample properly, but if you don't handle the tissue properly, then the diagnostic yield may still be not there. So make sure that good sampling is very, very important, but also proper handling is essential, because poor handling can lead to failure of your diagnosis of the failure of your procedure. Coming to rows, role of rows, it confirms adequacy in real time. It reduces inadequate samples and repeat procedures, and it guides us for need for additional passes and allocation of tissue for different tests. Rows again is a very important thing. However, we'll have another lecture for rows, so I'm not getting into details of it. But definitely, if possible, we should consider having rows in our bronchoscopy suite. Coming to operators' experience, there is a strong learning curve for EBUS TBNA. Yield improves with structured training, supervised procedures, and regular auditing. This, if we follow these steps, then our experience will improve and we will be able to do better in as we grow over the period of time. Initially, your yield may be a little less, but as you if you grow and as you try to audit yourself regularly, you may be able to improvise in giving the outcome better. And simulation-based learning helps the beginners. So we should make sure that when we are learning the EBUS TBNA, we may try with simultaneous-based learning, and then gradually we move on to do it in our own patients. Coming to multidisciplinary collaboration, again, we all need to understand that if we have a close collaboration with our radiologists, pathologists, oncologists, and microbiologists, our learning curve improves, our feedback loop improves our outcome, and pre-procedure planning becomes a very important key factor to decide how well we perform a procedure. Coming to common pitfalls. Now, there are certain common pitfalls which happens during the practice of EBUS TBNA. This includes poor scope stability, excessive suction leading to bloody sampling necrotic areas only. Initial days, sometimes you may not be able to identify where the necrotic areas, and you may land up in taking sample only from necrotic areas, and that can get to a poor outcome. Coming to over fixation or drying of specimen. Sometimes if you are making a slide and you over fix it or you make the specimen too dry, then the diagnostic yield may become less. Too few passes. If you are not doing 3 or more passes per lymph node, then the diagnostic accuracy may go down. Poor specimen handling and labeling. Failure to preserve tissue for molecular testing. Poor coordination with your team or the pathologist. So these are the common pitfalls which happens during the clinical practice, and we should try to avoid these pitfalls. Now, best practice checklist. This is very important checklist, not only for the beginners, but also those who are regularly doing it, because we often forget these important practical points. This includes proper patient selection, pre-procedure planning with your team, systematic nodal sampling, stable scope and real-time visualization, jabbing plus fanning technique, adequate passes, optimal specimen handling, rows, that is rapid on-site cytological evaluation, and MDT coordination. If we follow this checklist in every patient, then our outcome can become much better than what we are doing today. Now I come to the end of my today's talk, and the key take-home messages are: diagnostic yield is operator dependent. Patient selection and pre-procedure planning is essential for success. Technique matters more than needle size. Again, the very important thing for the beginners to understand that you need to improvise on your technique. Needle size most of the time do not matter much. Then sampling plus handling are inseparable. So need not only sample it properly, but also handle the tissue properly. Continuous training improves the outcome. And last but not the least, always communicate with the pathologist. With this, I end my talk today. Thank you.
A very good evening to all of you. At the outset, I would like to thank Chess Council of India for giving me this opportunity. So I'll be talking about ROSE and handling of tissue, pathologist perspective. So what is ROSE? ROSE is rapid on-site evaluation. That is, evaluation done rapidly and on-site. That is, quick assessment of the cytology samples for adequacy on-site, that is in the vicinity of the bronchoscopy procedure. It is a technique where an experienced cytopathologist or cytotechnologist is present in the bronchoscopy suite and guides the intervention pulmonologist in real time and allows termination of sampling after the acquisition of sufficient material for diagnosis and ancillary testing. Coming to the significance of ROSE, this technique ensures that the targeted lesion is sampled, thereby minimizing repeat procedures. It helps in rapid assessment of the adequacy of the samples obtained by EBUS TBNA and helps to improve the diagnostic yield. It helps in collecting extra samples for ancillary testing. That is, it helps in efficient triaging of the sample for ancillary studies like immunohistochemistry, microbiology studies, flow cytometry analysis, and molecular assays. It helps in rendering rapid preliminary diagnosis in ICU or urgent cases, thereby saving time. Hence, it is similar to frozen section evaluation of surgical specimens. Coming to the ROSE workflow, this is a picture demonstrating the ROSE workflow. The EBUS TBNA aspirate is expressed onto clean labeled glass slide and a smear is made. These smears are either air-dried or wet fixed, that is fixed in an alcoholic fixative. The air-dried smears are stained using stains like Romanowski stains like Diffvic or Giemsa, and the alcohol fixed smears are stained using rapid PAP or H&E stain. These stain slides are then evaluated under light microscopy by a cytopathologist for adequacy. If the smears are found to be inadequate, then a preliminary diagnosis is given. If the sample is inadequate, then the pulmonologist is requested to attempt more passes or move to another target if feasible. If the smears are adequate, a preliminary diagnosis is given. If the diagnosis is a carcinoma, then the pulmonologist is requested for additional samples for ancillary studies. This additional material is collected in either preservative like cytolite, fixative, or saline or formalin, and it is subjected to cytospin preparation or liquid-based cytology, and a cell block is made. The cell block can be used for immunohistochemical analysis for further typing of the carcinoma. The cytospin preparations and the liquid-based cytology smears can be used for molecular and cytogenetic testing. If the preliminary diagnosis is a granuloma, then the additional material is taken in normal saline and it is sent for infectious workup. If there is suspicion of lymphoma, then the additional material is taken in an RPMI solution and it is sent for flow cytometric analysis. Coming to the different samples and processing. So the samples can be either hemorrhagic samples or sometimes we get a coiled or a blood clot. This hemorrhagic samples, smear is made from these hemorrhagic samples and the additional material is taken in normal saline for cell block preparation. The coiled material and blood clot is taken in normal saline for cell block preparation. Sometimes the material is purulent and this purulent material is taken into normal saline and sent to microbiology for microbiological investigations. Coming to the technique of smear making, the coiled material of the blood clot is taken onto a clean glass slide with the help of this needle, and with the help of another slide, it is gently compressed and a smear is made. The technique of smear making is very important because poor technique causes uneven distribution of the sample and it can cause many artifacts, and this causes difficulty in interpretation of the smears. Smears should be limited in number. They should be cellular and optimal quality. So these are good smears and these are poor quality smears. Coming to the different artifacts, these are some of the artifacts that we routinely encounter in our day-to-day practice during ROSE. This is a crush artifact where too much pressure was applied during smear making. Hence, the cells are crushed and we cannot make out the morphology of the cells in such smears. These are the air drying artifacts. This artifact happens when the smears are not immediately fixed in the alcohol fixative. And this is a thick smear which happen when too much of material is taken onto the glass slide and a smear is made. And this also, overlapping of the cells also happen when there is too much material taken onto the glass slide. So the only adequate minimal amount of material has to be taken out of the glass slide and a smear has to be made. So different stains are there for rose, which different hospitals use. But out of all these stains, the toluidine blue is very fast, it is cheap, and it has very good nuclear material, and it can stain extracellular material. And these slides can be de-stained and again used for rapid and immunohistochemistry. Hence, toluidine blue is considered to be the best stain out of all these stains for rose. So coming to adequacy criteria for lymph nodes, a smear which is showing the representative sufficient normal tissue like presence of lymphocytes or lymphohistiocytic aggregates or germinal center fragments, the lymphocyte density with greater than 40 per high power field, these are considered to be an adequate smear. And even in the absence of lymphoid tissue, if there is a sufficient diagnostic lesion material like presence of tumor or granulomatous lesion, even then it is considered to be sufficient. Coming to parenchymal lung lesion, presence of microscopic anthracotic pigment is considered to be adequate. And even if these pigment-laden macrophages are not present, but if there is sufficient diagnostic lesional material like tumor or granulomatous pathology, it is considered to be adequate smear. But if the smears show only luminal cells, only mucus, only blood or necrosis, then they are considered to be inadequate smears. So these are some of the adequate smears. This is from a lymph node. We can see that the lymphocytes are more than 40 per high power field, hence it's an adequate smear. Here the smear is showing granulomas, here it is showing adenocarcinoma, here it is showing anthracotic pigment-laden macrophages. So these are all adequate smears. While these are inadequate smears because here there are only few epithelial cells, there is only blood here, there is only necrotic debris here, and this is an acellular smear. So these are all inadequate smears. So coming to some of the challenges which are encountered in rose, benign cells might mimic tumor cells and vice versa also can happen. Clusters of reactive bronchial epithelial cells might mimic adenocarcinoma. This is the most frequently encountered challenge. So in such scenarios, what we have to do is we have to look at the periphery of the clusters where the bronchial epithelial cells are thinly spread for presence of cilia, terminal bars, and columnar morphology. So all these features are pointers for benign reactive epithelial cells. And the other soft clues which we can use is we can look for the presence of background necrosis or discohesion of cells or marked ATPia. These are all pointers towards malignancy. The most important thing which we have to keep in our mind is always correlate the features with clinical imaging features, and meticulous evaluation of the morphology is very much essential. So this is the picture of reactive bronchial epithelial cells on the left, and this is adenocarcinoma on the right. We can see that both of them almost look similar. But when we see closely under high power, this at the periphery, there are cilia in these clusters, and there is not much of pleomorphism or atypia. Hence, these are reactive bronchial epithelial cells. While this cluster, when we see at the periphery, there is no cilia. Another thing is there is a lot of pleomorphism in these cells. Hence, it is an adenocarcinoma. This is how we differentiate between these two, reactive bronchial epithelial cells and adenocarcinoma. Coming to the other challenges which we encounter, sometimes reserve cell hyperplasia may mimic small cell carcinoma, goblet cell and squamous metaplasia may mimic non-small cell carcinoma, lymphohistiocytic aggregates and germinal center fragments of lymph node can mimic non-necrotizing granulomas. Diagnosis of small cell lymphomas can pose a very big challenge sometimes. Presence of monomorphic lymphoid population of lymphoid cells without germinal center fragments or tingible body macrophages are more of pointers towards lymphomas. So in all the above scenarios, the experience and knowledge of the cytopathologist is very much crucial for correct interpretation. So coming to the merits and demerits of ROSE, we have already seen the merits. ROSE helps in providing precise interpretation, perfect sample triage, accurate final diagnosis. It avoids additional investigations and delay in patient management, and it offers improved patient care. But the demerits include it needs experienced cytopathologists or dedicated trained cytotechnician, which is not feasible in many of the centers, and it is also a time-consuming process. So this is a picture from NAPCON where I was a panelist, and these were the questions that I was asked during the panel discussion. The first one was, what do you think about PROS? Does it help or hurt? The second was, how could we leverage technology to bring ROSE to the pathologist? The third was, what is the role of ROSE in lung nodule sampling? Does it increase the yield? Does it provide the information to the proceduralist that enhances patient care? So the third question I have already answered in my talk. And coming to the first two questions, the first question, what do you think about P-ROSE? Does it help or hurt? P-ROSE is pulmonologist ROSE. So it actually helps the pathologist because it saves him or her a lot of time. But the pulmonologist should be adequately trained from the pathologist. He or she should be aware of normal morphology of the cells routinely present in the EBUS TB and aspirates, the adequacy criteria, and the challenges and pitfalls. But again, these professionals cannot render a preliminary diagnosis and can only assess adequacy. This point is very much highlighted in this article, which is published in Archives of Pathology Lab Medicine. The second question, how could we leverage technology to bring ROSE to the pathologist? The simple way is send static images on WhatsApp, but the images should be clear and from the representative areas, and the pulmonologist should be aware that this method has major challenges. The other techniques is we can use video microscopy, we can do live streaming through a Zoom platform, or we can digitize this, the slides, and the whole slide scanned images can be sent to the pathologist for evaluation. So to summarize, ROSE is an important technique to estimate the adequacy of EBUS TB in smears, to increase the diagnostic yield, and to triage the samples for ancillary testing, thereby making this procedure the ultimate linchpin. It's akin to frozen section in giving the preliminary diagnosis, thereby helping the clinician in making further decisions. However, the operators and the pathologist skills, experience, and training plays a very vital role in the success of this technique. Thank you so much. I am happy to take up any questions.
Thanks to all the speakers for such wonderful presentations. Now we'll start our panel discussion so that whatever points we have discussed in the 3 lectures can be further elaborated and make it simple for the listeners who are here in today's webinar. And we'll try to see that you have at least few take-home messages when we end this webinar. Now let us start with the panel discussion. My first question is to Dr. Vrushali. Dr. Vrushali, how much weight do you give to PET CT scan findings when deciding which nodes to sample and which to avoid? So what's your take on that?
Yeah, good evening, everybody, and thank you for the question, sir. Basically, your pre-test probability of a benign versus a malignant lesion is where you decide whether you want a PET CT. Per se, with a benign pretest probability, I wouldn't really go in for a PET CT. But if malignancy is on the back of my mind or it is on cards, then definitely PET CT helps us in deciding, the lymph node stations, like you yourself mentioned in your lecture, that you go from the N3, N2, you kind of go to the farthest kind of lymph node. And the other thing is, what happens is with the PET CT is you can see the uptake of the lymph node. So it's like you just mentioned, a distinct margin, the size. So those ways, it's also shown that when you have a PET along with a CT, the biopsy yield goes up by 93% vis-a-vis the 79 when you're using only in terms of using a CT scan. With a PET, you can also see some bronchular lesions also, which you might want to sample at the same time. So it gives you a wholesome picture as to which are the various stations which you can sample. So basically, sequential sampling helps increase the yield, and therefore a PET CT is very important when you go in for a malignancy kind of a diagnosis. Benign, I would really not be in favor of a PET.
Do a PET CT in benign cases normally. Yeah. If you're suspecting a benign lesion, we don't do a PET CT. We are talking about malignant cases.
Yes.
So I think now we move on to our next question to Dr. Bala Raju. Dr. Bala Raju, do you routinely sample nodes less than 10 mm if PET positive? Or do you apply a size threshold? How you handle the lymph nodes which are less than 10 mm? This is something important which we always struggle in our practice, that whether we should sample them or we should restrict our size to more than 10 mm, which we normally do in a CT scan. So what's your take on it?
Yeah, so you can broadly divide this into 2 categories. One is the staging part and one is the diagnostic part. So if you're doing a staging EBUS, so if the lymph node size is less than 10 mm and if it is PET positive, 100% you're going to sample it. But there are technical challenges when you're doing less than 10 mm that will come to that. So second point is if the lymph node size is less than 10 mm, it is PET negative, still we sample in a staging EBUS. So the challenge is to do a very good sampling for that less than 10 mm lymph node. So what I have seen is the best way to do it is take the patient under general anesthesia. So most of the times our diagnostic procedures, we do it under conscious sedation. Still, I do it under conscious sedation. But what I've seen is less than 10 mm nodes, it is very, very difficult to do it under conscious sedation. It is better to do under general anesthesia. You can use temporary paralysis if you want. That my point to be noted is these 10 mm lymph nodes are tricky. It is not so easy. And most of the times the sample is inadequate. That's what the report you get most of the times. So to get the best sample for this 10 mm lymph nodes, I feel the technique is very, very important. So this is the staging part. And coming to the diagnostic part, see, in your talk and in others' talk, you already mentioned that more than 3 to 4 passes per lymph node, and you have to select at least 2 stations when you're doing a diagnosis. And most of the times, believe me, you don't have to bother about less than 10 mm lymph nodes because you will have more lymph nodes to sample, whether it is 4 or 7 or wherever it is. So I feel this is especially important for a staging EBUS. So less than 10 mm, positive or negative, I think we should sample the lymph node station at least. That's what I feel.
Okay, thank you. And that's really insightful. I think now we move on to a next question to Dr. Pravin Taware. Dr. Pravin, do EBUS ultrasound features of lymph nodes help in pre-test diagnosis? Again, this is a important message we want to give to the beginners. That does the EBUS, the features of the EBUS on the endoscopic ultrasound images, does it help us to make a diagnosis pre-test or presume that these are the most likely diagnosis in that case? And are there specific signs to suggest malignancy? Dr. Pravin.
Yeah. Yes, sir. So there are some signs which favors malignancy, where you see a bigger nodes, round node, very distinct margins are there. When you have central coagulation necrosis, or when there is like absence of intranodal vessels, or when you don't see, which is most of the time we see preserved central hilar structure. So if that is lost, that favors malignancy, but again, it doesn't replace the tissue diagnosis. Anyway, we'll have to go for tissue diagnosis, whether it is there is lymph node features or not. We have to go for tissue biopsy. So again, there are few things what we need to understand is there is no single specific mediastinal lymph node, any characteristic can distinguish between benign or malignant cells. So based on pretest probability and combination of sonographic lymph node features, you can help. It can help in giving differential diagnosis, but obviously not replace the biopsy.
Okay, thank you. My next question is to Dr. Vrushali. Dr. Vrushali, now choosing the needle. Again, sometimes it becomes difficult, and there are always, like, everyone has their own choices. According to you, which one is better, 21 gauge or 22 gauge? And does the size truly impact the yield, or is the technique which is more important? What do you say on that?
So you've already mentioned well that it's the technique which is more important, and my choice, rather than my choice, there are enough papers which have shown that, it is not the size of the needle which is helping. It is usually the needle technique which is important, because contrary to the belief that a larger needle size will give us more tissue, in fact, a larger needle size might have more crush artifacts, there may be more blood, and which can be a hindrance once you want to diagnose a malignancy or some such thing, So basically, there are multiple papers which are showing that the sensitivity and the specificity is almost similar if you're using a 21 gauge needle. and even we do not really need to go the 19 gauge one in most of the cases. In fact, there are papers on lymphoma particularly where they've seen that the 19 gauge has lesser yield as compared to a 22 and a 21. So for me, if you ask me, currently my available thing is 22 gauge, and we are getting, almost, a good diagnosis. And like I said, it's not my personal thing. It's also what the literature has shown.
Okay, thank you. Maybe if you want a bigger tissue, sometime or larger tissue, especially in lymphoma or benign conditions, sometimes we use 19 gauge, but there are only very selected situations. Yes, there may be a difference in opinion on that. Problem with Indian scenario is your histopathologist a lot of time asks for a bigger tissue than what we don't have very good histopathologist and cytologists in India. So sometimes, especially when I feel when we're suspecting a lymphoma, we try to go by 19 gauge. I know that the data may be not very great, but then that's what a lot of us do. Do you agree, Dr. Balaraju? If you suspect lymphoma, you go for bigger, or no, you still go for 20?
My personal experience with 19 gauge is not so great. I think it's with most of the people. So
Okay.
I have given up 19 gauge completely. So not at all
Okay.
using.
You use only 21 gauge.
Yeah,
Or
I
22.
use only 22. So
22.
22 I use regularly.
22.
I didn't have many issues. I don't know when was the last non-diagnostic EBUS I had. So it is not so common.
Okay.
So what I feel is especially for station 4L and 10L. So these two are very tricky stations. The 4L and the 10L. So even though if you use a 22 gauge needle, sometimes even though when you're seeing the lymph node, when you put the needle inside, you will never see the lymph node again. So 4L and 10L, especially 10L. So in these cases, I use 25. So 25 has a better bending capacities than 22. So yes, you can comment on the yield, but my own point is when you don't see the lymph node properly when you're jabbing, you don't have confidence in getting the tissue. So this is point one. So point two was specifically to your question, lymphomas. So I have told you that I've given up 19 gauge needles. So now I only do a cryo intranodal biopsy that has given far, far, far superior yields compared to any of the needle available. This is what I feel currently now. So currently we have given up. I have given up 19 gauge completely. I'm only using intranodal cryobiopsy. So with better results.
I think we have now moved on to cryobiopsy, in especially in lymphomas or benign lesions sometimes, and those which are negative EBUS, we move on to the cryobiopsy. So I think that.
Can I just pitch in, sir, over here? Can we just ask Dr. Sharada that what is, with these small needle sizes, how does a flow cytometry, which is, has she seen a difference between the intranodal forceps biopsy and the flow cytometry if there are enough samples which she's received in terms of for the lymphoma, particularly since we were on lymphoma?
You mean the difference between the needles?
No, not the needles. We are speaking about, just Dr. Balaraju said that, the 20, he is doing the intranodal forceps biopsy and a cryobiopsy, which is what has been proposed for both sarcoidosis and lymphoma. But now considering that the flow cytometry, if you're using a 22 gauge needle, which most of us are using, I believe 19 gauge is no longer available.
No
for
longer
us,
available,
21 is not also available.
Yeah.
So in that case, you would prefer the flow cytometry over the intranodal forceps biopsy or the cryo, or how is it?
I always prefer a cryobiopsy because that gives more tissue.
Yeah.
And like especially in lymphomas where we have to use,
Architecture.
suppose if we are using
architecture
is
the
one
cortex
thing.
to the
Yes, architecture is one thing. Another thing is lymphomas. Sometimes we have to use a panel of immunohistochemistry markers to subtype the lymphoma, especially in a non-Hodgkin's lymphoma. So we need more tissue to do that panel of IHC markers. So I always prefer a bigger tissue for a lymphoma.
So that is absolutely my pathologist has told me. Absolutely same thing my pathologist has told me. When I asked for flow cytometry, I said, just leave it, just do a cryobiopsy and give it to me. That's what he said.
So I think for difficult cases and lymphomas and benign conditions, now all of us are switching towards cryobiopsy. And those which are negative EBUS, so cryobiopsy may help in this situation. I think that's a very important message. Now we move on to the next question, which is to Dr. Supreet Batra. Dr. Supreet, in the absence of REVOs, what is your minimum number of passes per node? Does the pre-procedure diagnosis influence this? And do you change the strategy when molecular testing is anticipated? I think most of us have discussed it, but I think I want your point of view. What is your take on this?
Yes, sir. While doing a EBUS, normally we take 3 to 4 passes, and if our probability is more of a malignancy, we usually take more than 6 passes. So that is what we do because we need more tissue. So since we have no rows, we try to get whatever maximum tissue possible. And if you suspect there's a tuberculosis and all, so we usually take 3 to 4, but minimum 3 to 4 passes per node we take. And just wanted to comment on the previous things. The PET CT, the first question was, it also shows us the extra other sites where the tumor can spread. That is one thing. And as Dr. Bala sir said, that there's a node, I had a case where there was a node only 4L or 0.8 mm. So that 10 mm criteria is not there because sensitivity of PET is 10 mm, but EBUS sensitivity is less than 10 mm. So what I mean to say, even if a node of 10 mm, less than 10 mm, it should be biopsied because in a high test of probability of a malignancy, it usually turns out to be a malignant. And if usually it's a single node, well defined, we must does not bother about size and we should sample it. So that
you can sample the lymph node, sample
yes,
it.
Yes, sample
especially
it.
if it is PET positive.
PET sensitivity is only 10 mm. It can pick up node more than 10 mm. But EBUS can pick up nodes less than 10 mm.
Otherwise, also, if you are having a malignancy for staging, even a smaller lymph node should be sampled.
Yes. So even a 0.6 mm node can be turned out to be positive.
Okay. Yeah, that's true. Yeah. The next question is to Dr. Pravin. Dr. Pravin, how many needle passes are recommended per node in suspected, I'm talking about different clinical situations, suspected lymphomas, malignancies, sarcoid and TB. What are the recommendations? Because we need to understand the audience, the beginners need to understand that how much they should take, how many passes, and which are the situations when they are supposed to take more passes than the 3 which we normally recommend, 3 to 4.
Yeah, so as you mentioned, sir, 3 to 4 passes are mandatory per lymph node. That is very important, not in total. Per lymph node, 3 to 4 passes. If you are suspecting malignancy, if your oncologist is asking to send for molecular testing and NGS, then the next 2 passes should go in formalin and further testing. If you are suspecting sarcoidosis, you don't need more than 4 passes, 3 to 4 passes, or tuberculosis or any benign condition. If you are suspecting lymphoma, as Bala sir already mentioned, you need a bigger chunk. So either you go with 19 gauge needle or you go with cryobiopsy if facility is there. So here passes and course are different. So if you are having 3 to 4 passes per node, and if you are targeting 2 nodes, so you got 8 passes, like that, 8 cores, and then you can divide as per your pre-test probability. You can triage as per your suspected diagnosis. If it is malignancy, I would put 3 to 4 cores for in formalin, and I'll make sure I'll give enough sample for cytopathologist and for molecular diagnosis.
So there's a question which is from the audience, that if you get 2 good cores, still you need 4 passes, or you will restrict to 2 only? So that's a question from the audience.
Yes. So again, sir, so if even if you suspect malignancy in our country, you need to make sure you are sending for microbiology. So for gene expert and for AFB culture, you need those 2 extra cores. So always make sure you'll get enough sample.
Yes, I agree that in India you should send for gene expert and TB culture, because sometimes you get you have a different diagnosis altogether. You're thinking of malignancy, it turns out to be TB. Even in cases of malignancies with lymph node, we have found a couple of situations that the patient also had tuberculosis along with it. So I think we should always send for gene expert and TB cultures in Indian scenario. Yes, Dr. Supreet, want to say something?
Sir, the latest ACCP guidelines say that we should avoid the word core now, because it's not a core, actually it's an aspiration. That is one thing. Second thing is, if you are taking a passes and if you see it's a malignancy, you have to take additional 2 passes. So you have to make now 6 passes, because for molecular testing and for other cell block. So that is why even if you get good sample, you must take, they say the guidelines say you must take 6 samples, 6 passes.
Okay. So for molecular testing for malignancy.
And for cell.
Thank you. Thank you, Dr. Supreet, for this information. Now we move on to our next question to Dr. Vrushali. Vrushali, is ROSE essential, or can good yield be achieved consistently without it?
So according to our own Indian guidelines, they said that ROSE is not mandatory. But what ROSE does is that it increases your confidence in what you're sampling. Okay. It also shows the adequacy of the sample. So like we just mentioned that if you have a ROSE, then a 3 passes should be sufficient. But if you do not have ROSE, for some reason you do not have ROSE, then 5 passes will help us. ROSE also helps us find out whether we're getting a lot of necrotic tissue from whatever lymph node. Sometimes you get a sample site which is from the necrotic. If it's necrotic, you can change. Though as a rule we do it. But for a person who's a beginner, yes, ROSE will definitely help them in understanding that where they are, if they're getting too much of bronchial epithelial cells, or they're into the tissue.
So, availability of ROSE is very restricted in India. I don't think many people have it. Though we talk a lot about it, but in real world practice, I don't think many centers have it. It's probably
it's not necessary. It will help you build your confidence and things as to what you are sampling, but it's not necessary. But yeah, if it is there, then it will definitely improve your yield. It will also tell you that whether you're short of whatever, you think you have taken a big sample size, but it doesn't give you a representative material.
Okay.
But turns out to be a blood clot.
But it's not mandatory. Yes, sir?
Sometimes it turns out to be a blood clot. We think it's a core, but it turns out to be a blood clot.
Yeah. Very common. It may happen that way. Okay. Now my next question. Dr. Pravin. Yeah, please.
Yeah. So even sometimes blood clots are very helpful, because when our pathologist has picked up cells on blood clots, and even like sometimes we don't get we get a non-diagnostic sampling and only blood clot is picking the malignant cells. So don't throw away the blood clot, keep them in formalin or saline, wherever you want to triage, and always push the saline through the needle so that you can make cell block also out of that.
Okay. This question is to Dr. Sharada. During ROSE, when do you consider material adequate, and what are the common smear preparation pitfalls? Dr. Sharada, please.
Yeah.
And also we want to have your input on the previous discussion on the blood clots which comes along with the EBUS TBNS sample. What do you say about it? What is the experience on that?
So the first question, coming to the adequacy first, adequacy of ROSE. So for cytology, if the ROSE is performed from a lymph node, if it is a lymph node aspirate, the adequacy criteria is more than 40 lymphocytes per hypa field or presence of germinal center fragments. For a parenchymal lung lesion aspirate, the adequacy criteria is presence of anthracotic pigment-laden macrophages. For both lymph node as well as parenchymal lung lesion aspirates, if there is a presence of lesional material, whether it is a granuloma or malignant, even then the smears are considered to be adequate. And coming to bronchial epithelial cells, the bronchial epithelial cells in the smear should not be more than 2 clusters per low PAR field. So these are the adequacy criteria for cytology. Now coming to the adequacy criteria for molecular testing, the smear should contain more than 40% tumor cells for RT-PCR. And for NGS, the smear should have more than 50% tumor cells. And for a PDL1 testing, the stain slide from a cell block should have more than 100 viable tumor cells for PDL1 testing. So this is adequacy criteria for molecular testing. Now coming to the technical pitfalls. So the most common technical pitfalls that we commonly encounter are poor smear spreading. The spread is not uniform, not even. The others are, thick smear. Thick smear is made whenever the material that is taken is more. The excess, then a thick smear is made. In that case, it is very difficult to interpret the morphology because there is overlapping of the cells. The morphological details are not clearly seen. So that is one thing. The other things, the other artifacts that we encounter are crush artifact. When, a lot of pressure is used while making the smear preparation, we get crush artifacts. and then we get air drying artifacts when the smears are not immediately fixed to the alcohol fixative. So these are some of the common technical pitfalls that we encounter during smear preparation. The other thing is, as Dr. Pravin is saying, I completely agree. Please don't waste any material, even if it is blood clot, even if it is very small tissue pores, even if it is excess blood. Please put all the material in the fixative and send it to the lab for cell block preparation.
Yeah.
Because sometimes even if the cells are very scant, we can use that cell block for immunohistochemistry.
Thank you, Dr. Sharada. I think continuing of the same question, do you recommend preparing a cell block in all cases, and what practical steps can a bronchoscopist take to improve the cell block quality? So need to know from you.
Yeah. So I recommend doing cell block in all the scenarios, because cell block, first thing is it helps in diagnosis. It helps in typing of the malignancy. It helps in doing immunohistochemical analysis and also molecular testing. So cell block has a lot of advantages. It increases the diagnostic yield, and it can be used for all these ancillary testing apart from diagnosis. So I do cell block. I recommend doing cell block in all situations. That is the first answer. And the second, what are the steps that a bronchoscopist has to be taken? The first step is the bronchoscopist should be sure that he is taking the material from the representative lesion, and that the material is having viable tumor cells and it's not just necrotic material. That is one. The second step is he should make dedicated passes for cell block. Means don't just use only the leftover material for cell block. Please make dedicated passes, because as I said, cell block can be used for many purposes. So please make dedicated passes. The third one is, as I've already said, don't waste any material. Whatever material is there, even the needle, as Dr. Pravin rightly pointed out, even the needle also has to be rinsed with normal saline or air, and the extra material, the material that is left over in the needle rinse, even that is also very helpful, whether it is needle rinse material, whether it is blood clot, excessive blood, or even if it is tiny fragments. Please put all the material in the fixative and send it to the lab for processing. And next is coming to the fixative. A proper fixative has to be used for cell block preparation. So the most commonly used are normal saline and formalin. And this, whether it is normal saline or formalin, it depends upon the clotting agent that your lab is using to make the cell block. So different labs use different clotting agents. So depending on that, you can use either normal saline or formalin. But the most widely used is 10% neutral buffered formalin, because normal saline causes disintegration of the cells rapidly. So I prefer fixing the fixative to be used as a 10% neutral buffered formalin. That is one thing. Another thing is, make sure that the quantity of the fixative is adequate, so that all the material, the entire material is immersed in the fixative properly and it is getting fixed properly. So these are the different steps that a bronchoscopist has to take.
Thank you, Dr. Sharada.
Sir, I have one question.
Yeah, please.
Ma'am, do you recommend that we should prepare a slide before taking the sample?
Yes.
And the other thing is, what medium you say? Sometimes the liquid, the LPC. What about the LPC? Liquid.
So LBC, yes, liquid-based cytology.
Cytology.
So, yes, this is used in some centers where they have this LBC machine. It is an automated machine. So they have their own fixative. Like Cytolite is used for Trimprep and SurePath solution is used for the SurePath. So, so in this case, is the entire aspirate is to be transferred into this solution, whether it is Cytolite or SurePath solution. Transfer the entire aspirate into this solution and then send it to the lab, and the lab will make they will have their own, they will have these LBC machines, and they make an LBC preparation, LBC smear from this aspirate. And these LBC smears are far more superior to when compared to the normal manual smears, because they are thinly spread, there is no overlapping, and even the blood, they are like clean slides. They don't have blood also. So always, whenever there is a possibility, LBC smears are preferable when compared to the manual smears.
Thank you, Dr. Sharada. I think we move on to our next question. This is to Dr. Bala Raju. Dr. Bala Raju, what are the most common reasons for a non-diagnostic EBUS, and how do you manage such cases? Another important question linked to the same is that how often do you repeat the procedure in your practice?
Yeah. So most commonest causes for non-diagnostic EBUS is one, wrong nodal selection, one, or the wrong part of the node which is selected. Two, probably less number of passes, or the technique is entirely wrong. Especially what happens if the patient is not, this is what my practical problem I have seen. When the patient is not properly sedated or if he is coughing excessively, you tend to do less passes. So this is a real practical problem I have seen in many of the centers. So the best way is when you're not able to do your passes, I feel that you have to take the patient under TIVA or a general anesthesia, even though it's going to take some more time. The problem here is if you don't take adequate samples upfront, then your chances of rebiopsy increases. That's what I feel. In most of the centers, this is what is lacking. One, probably they are not using the right anesthesia to make all the passes and to select the node. This especially happens when you have nodes at these two important locations. One is the 4L and the 10L. So these are very, very tricky stations. These are not so easily accessible as 4R or 7 or whatever it may be. And lucky for us, most of our EBUS is either 4R, 7, 11, 10 or 10R or something. Most of the times. In less than 20% of the chances, only the 10L and the 4L have to be sampled. So I feel this is part one. And part two, I forgot what you asked. What was the second question? How often do I do
how often you repeat an EBUS or you go for some other way to take the sample? If your first EBUS is negative, then would you repeat a EBUS or you go by CT guided biopsy or some other way to take the sample?
So I don't remember when was the last time I have to do a repeat EBUS in my case. Usually what happens, again, madam has already touched it. Vrushali madam has already touched it. It all depends upon your pretest probability at what you are trying to deal upfront. So most of the times you will get at least some kind of clue, like what is this node or a lesion what we are targeting, whether it is a granuloma, lymphoma, malignancy. That's what I categorize into three: granuloma, lymphoma, malignancy. If your pretest probability says is lymphoma, yes, you upfront get ready with intranodal cryobiopsy. Otherwise, usually I don't do any intranodal cryobiopsies for all the cases. I don't do rows. I do all the 4 passes per lymph node station. I don't do rows in my center. So I feel that if you stick to that technique part and get adequate samples, most of the times your EBUS yield is more than 90%. That's what I feel.
Thank you. Now, my next question is Dr. Supreet Batra. Dr. Supreet, how do you approach necrotic and cystic appearing lymph nodes? I think that's something very important and we often encounter in India having necrotic lymph nodes. So what do you do for them? How do you approach them?
Yes, sir. So, if there's a node is necrotic, we usually use aspiration or suction because sometimes we get a pus also. So in that case, we use a suction as to see if there is any necrotic material is there pus. That is a thing. And passes, we know that it's a necrotic material, so we send them for cultures, more for cultures, and rather than preparing less of slides.
Thank you. I think that's important that even if it's necrotic lymph node, you still do 4 passes, 3 to 4 passes, and send the tissue properly for cultures and histopathology both. And if you are able to see any part of the lymph node which is non-necrotic, we may try to take a sample from that part of the lymph node. I think that may add on. Do you agree, Dr. Supreet?
Yes, sir. Yes, sir. If we are suspecting that it's a malignancy, also definitely we don't target the necrotic part. We tolerate the solid part. But if it is fully necrotic node, then we try to do a suction first to see if there's some pus material and is there or not. So in that case, we get a good sample yield.
Okay. Thank you. Now the next question is to Dr. Sharada. Dr. Sharada, how do you approach granulomatous inflammation detection during rows?
So whenever I encounter granulomas on the smear, so first thing is I look for the morphology, whether these are well-formed granulomas or loosely formed granulomas. If the granulomas are well formed, then that goes more in favor of sarcoid. And if the granulomas are loosely formed, then that goes more in favor of tuberculosis, mycobacterial infection. And the next thing is I look for the background, whether there is any necrosis or any neutrophilic infiltrate in the background. Presence of necrosis and neutrophils again goes more in favor of tuberculosis. And so having said all this, I would like to highlight this point that we cannot reliably distinguish between sarcoid and a mycobacterial infection based only on cytology, unlike in a biopsy. In biopsy, we take into consideration many other soft clues like presence of lymphangitic distribution of the granulomas, then absence of organizing pneumonia, absence of inflammation in the surrounding lung parenchyma. All these go more in favor of sarcoid. And so in biopsy, we have all these soft clues, but in cytology, we don't have these clues. So that is the reason why we cannot reliably distinguish between a sarcoid and a mycobacterial infection based only on cytology. Another point I would like to talk about with regard to this granulomatous inflammation is certain tumors like Hodgkin's lymphoma and germ cell tumors, they are associated with granulomatous inflammation. Okay. So the pathologist should always keep this in mind, not to miss out any tumor in the background, especially when there is a strong clinical and radiological suspicion.
Okay, that's really an important thing for us to learn, that yes, sometimes even malignancies can have granulomas with it. So yes.
Sir, one question.
Yeah, please.
Ma'am, do you do staining also on the sample? Because sometimes AFB staining can give you positive diagnosis on your pathology samples.
Yes.
Because sometimes it has happened, my microbiologist is not able to find the AFB, but the pathologist has found on the sample.
Yes, there are situations when the pathologist
there are a lot of situations like that. We definitely do. When there is necrosis, when there is granuloma, even if the granulomas are well formed, definitely we do a ZN stain for AFB.
Yeah, thank you. My next question
we
is
also do fungal stains.
Okay.
We also do fungal stains.
Yeah, especially in immunocompromised patients, sometimes you get fungal infections there. Yeah, thank you. My next question is to Dr. Pravin. Dr. Pravin, if the patient starts coughing intensely while the needle is inside, again, a very practical question for you. When the needle is inside the lymph node and patient starts coughing intensely, how do you manage the situation?
Yes, this is very common, sir. So if the patient is under a light sedation and patient is coughing very intensely, then remove the needle immediately, or you can withdraw the needle inside the sheath, and so that needle related injuries can be avoided. And then deepen the sedation. Ask anesthesiologist to deepen the sedation and then proceed. Or if patient like cough is not so intense, then you can keep the needle inside and then ask anesthetist to deepen the sedation and then continue. Or if you feel or anesthesiologist is not comfortable with IV sedation, then you can proceed with general anesthesia or controlled ventilation, like in few cases we do, and ask anesthetist to give relaxant if you are requiring relaxant, because a lot of times what happens when there are respiratory movements, there are a lot of respiratory movements, and that's why you are sometimes your vision get lost. So we use atracurinium or vecurinium as a relaxant. If there is CKD patient, we usually use atracurinium. If there is a normal patient, we use vecurinium. And because all these can be reversed with all reversal agents very easily.
Most of the time we don't need it. What is your opinion, Dr. Bala? I hardly require paralytic agents in my practice. We always do in conscious sedation. Very, very uncommon to convert to GA. Very, very uncommon for paralysis. So I think most of the time we are able to do with a deeper conscious sedation, maybe.
In fact, I don't do any of the iGel or endotracheal tube.
We also don't do it. We do it under.
I only do it under deep sedation with an nasopharyngeal airway. I found out that if keeping a nasopharyngeal airway in place has a better control over ventilation than just giving oxygen. And the second point is, I only do general anesthesia in high-risk patients, especially if you have obesity. That's what really matters. If you're having a thick neck, large face, obese patient, you have to do an EBUS. And these are tricky patients, which you will not able to do it under deep sedation. Also, in cases of SVC syndrome, So these cases also, they are not easy to do it under deep sedation. Or if you're doing a small lymph node, especially this point has been touched, when you are doing a small lymph node and you want to do it a good technique. So this point has been mentioned, the motion artifact which comes with the deep respiration, you are not able to puncture the lymph node at the exact size. Only in those cases, I might require general anesthesia. Otherwise, in most of the times, at least I should say 95% of the times, we don't require a general anesthesia at all.
And also for staging, sometimes we do it under general.
If the procedure is getting prolonged, then yes, sometimes we do it.
Yes.
My next question is to Dr. Supreet. Dr. Supreet, how do you manage bleeding during EBUS TBNA?
Yes, sir. So before doing a pass, we usually use a Doppler to see whether there's a lymph node, there's a vessel or not. So if there's a vessel, big vessel and all, we usually avoid that vessel targeting. But we have seen usually the bleed during the EBUS is very minimal. It usually stops by noon. So need not worry about the small bleeds. But if you have punctured a vessel, then like sir said, SVC syndrome, I had a case of an SVC syndrome in which I tried to biopsy 4 hours and it started bleeding very badly.
Okay.
So because it was engulfing that. So that's what there are some tricky cases where we have to use a Doppler when we are the lymph node is near the vessel and try to target and keep should keep ourselves and seeing the needle throughout and do not cross the texture or the boundaries of the lymph node and keep the jabbing as from the one end to another end, but keep the control over the needle so as to avoid and puncture any vessel nearby.
I think that most of the time the bleeding is very minimal and we don't need to do anything about it. And if some major bleeding like what you have mentioned happen, then you cannot do anything about it. You have to call a surgeon in the critical care team for the help you. So I think for EBUS, if there is a bleeding, you don't worry about it. Usually it settles by its own. That's what the message we want to convey to the audience. The next question is to Dr. Bala. What technical mistakes are most commonly seen in early EBUS operators? What is your...
We already touched upon. One is the wrong nodal station. Two is in the node, targeting the wrong part of the node. When you don't target the exact part, probably you will not get the needle. And three is the technique. So needle jab technique is very, very important because most of the times when you do a needle jab, it might hit the cartilage. So you have to make sure that it is not hitting the cartilage, it is going exactly at the intercartilaginous space. And three is wrong number of passes. If you don't take adequate number of passes, again, your yield will come down. So this is what I feel beginners should be focusing on to correct the technique properly so that you will get a better yield compared to previous parts.
I think, can I just add one thing?
Yes, please.
They're quite hesitant. So either if they're hesitant, their travel is too less, or they tend to keep on coming out of the node. So like when we're training, this is what we've observed. So this is another thing. They have to maintain themselves between the cortex to the cortex of the other side, and possibly for the necrotic nodes also, going from cortex to cortex can increase the yield, where you have these patients of malignancy and also, teaching the cortex to cortex kind of a travel with the needle.
Okay.
And also, sir, if as a learner, you should target bigger nodes and also subcranial.
7 and 4 hour.
Yeah.
7 and 4
It is
hour.
not for the learners, even it's for the regular people we target it.
So most of the time, 7, if it is enlarged, you take a sample from there and then move on if you have more lymph nodes. So now the next question again is to Dr. Vrushali. If you could improve yield with just one change in your current practice, what would be that?
So currently, I think, not to sound too pompous or something, possibly, pre-workup is good. The imaging is all right. The indication is all right. The nodal station is all right. So currently nothing. But what we have done is initially we used to make a lot of slides and waste material on that. So now we make it only a single slide and ensure that most of the material goes into, if you have a pre-test probability of malignancy, into the formalin, and otherwise into the saline. For example, like Dr. Pravin said that, you always ensure that there is enough material for the culture. Sometimes because in the initial pass, you might just get a lymph node and you might tend lymphoid cells without actually getting any kind of a thing. So basically, I think I get a bit more sample in the normal saline, and soon as I'm sure, with the passes, our rows happens not really rows. It's like 20 minutes post whatever we've done. By the time the entire procedure is done, so we can at least tell the pathologist, immediately transfer to this. So particularly from my end, I think if you following whatever has been told in the first three, lectures by you all, I wouldn't really like to change anything. Having a rose, it kind of gives me a confidence that I have told even in the beginning, and I think take as much sample in the cell, in not on the slides, but in either the formalin or the NS.
Okay, thank you, Dr. Vrushali. My next question is Dr. Supreet. Dr. Supreet, in which situations you consider using EBUS cryobiopsy? Which are the specific indications? What is? I know this may be a little repetition, but I think we should be very crystal clear in what are the specific indications for cryo.
So the cryobiopsy, nowadays people are using upfront because to get a good tissue. But the thing is, the main indications are if you're suspecting a malignancy, to get higher tissue for cell block and nuclear genome sequencing NGS. Other is lymphoma. That is the second one. And third, if you have a negative ROS or a negative EBUS on the first time. So then definitely second time you don't want to take a chance. But nowadays people are using upfront. So I think that
probably that may be a little do it. Probably we will stick to the routine EBUS TBNA, and if that is your ROS is negative, or if you're not getting enough tissue, or you're suspecting sarcoid or lymphoma, maybe we can consider doing a cryo. Otherwise, your routine EBUS TBNA is usually enough. I think all the panelists agree with that.
Yes.
Yes.
Yeah.
So even I don't do an upfront cryo. It's always after an EBUS.
Okay. Oh, thank you. And now we move on to our next question. Now this question is to Dr. Sharada. Dr. Sharada, as a pulmonary pathologist, what are your expectations from a pulmonologist performing EBUS TBNA regarding triaging, slide preparation, and handling material for auxiliary test? I think you need to summarize, and this is like give a proper message to all the pulmonologists. So what do you normally expect from them? How to handle the tissue? So maybe can you give a summary of it so that the pulmonologists understand that this is the way they need to send the sample? We always expect from pathologists, but we needed to know your expectations from us.
So first thing is the material should be representative of the lesion. It should have, as I've already said, it should have viable tumor cells or the lesion, and it should not be just necrotic material. So the first thing is it should be representative. The second is the material should be adequate in the sense not only for diagnosis but also for it should be sufficient for molecular testing. Third is the material should be sent in proper fixative and also adequate quantity of fixative, as I've already said. And the next is the smears and the containers should be properly labeled. Labeled in the sense the site has to be mentioned, the side also has to be mentioned, whether it is right or left side. So they should be properly labeled and then said. And the final, this one is the test request form, which is sent along with the sample. The test request form should be completely filled. The site has to be mentioned, the site has to be mentioned, the indication for EBUS has to be mentioned, and along with that, even the relevant clinical and imaging details also have to be mentioned. So these are the expectations as a pathologist from the pulmonologist.
So just one more important thing I want to ask you. When you are taking a EBUS sample, should we just make one slide from the TBNA aspirate, and then we send rest of the tissue into the fixator for the cell block, or we should make multiple slides? What do you say?
Sir, at least one air dried smear and one alcohol fixative smear.
Okay.
At least one of each we require. Because air dried smear, which gives us more of, the cytological details in the extracellular material, like mucin and all, they are like better defined in our air dried smears because we use Ramanowski stains for that. And then the alcohol fixed smear, at least one alcohol fixative smear we need. And the rest of the material can go into for cell block preparation into the fixative.
Okay, thank you. Now, my next question is to Dr. Vrushali. Do you routinely audit your EBUS outcomes and has it changed your practice? Do you think that's important or no?
So absolutely, sir. There's no two ways about it. We routinely audit it. What could have been done better. I mean, it's a routine practice for us. It happened when we started also for the initial 10 cases, and after that, it has been a regular feature. So we again it goes down to the ABC. Preoperative planning, availability of the imaging, what is your pre-diagnostic thing, how you've done the procedure, not cutting down on the number of passes which are necessary. It does help us, sir, definitely.
So again, auditing an important part of your practice. So
Everything,
we
your
always
clinical, your procedure, I think, and self-audit and auditing of your team also, I think it's
we do
something
regularly in the
come to.
department in
Yes.
everything now. We
Yes.
evaluate ourselves maybe every quarterly that what we are doing and how we can make ourselves better. So I think that's an important message. Now, next question is for Dr. Bala Raju. How critical is communication with the pathologist in improving the diagnostic yield? What do you do in your real world clinical practice? Do you communicate with the pathologist or it's not there?
Yeah. So, ma'am
And I
has
would say also
already.
communication with your radiologist for that sake.
Yeah, true. Ma'am has already touched upon all those three because, again, broadly dividing into during the rows, malignancy, granuloma, and lymphoma. But my problem is I don't have a rose in my center. So most of the times it is just after the procedure is done. So the communication is only after the procedure is done. So what I do in my practice is like what ma'am has told. The first pass is always a slide. So I usually do all slides in the first pass. If it is a good pass, then no more slides. Just directly put all the next material comes, whatever comes, into the saline sample and the 10% neutral buffer formalin. Only these two. So, and just pray to God and you get material in that. And speak to the pathologist like every procedure is an exam for me so that did I pass or not, because I don't have the luxury of rows in my center. So it is only the communication is only after the procedure. It is unfortunately
I think when we
not
talk
during the
to
procedure.
them, when we call up and talk to them that what are we expecting and what are we looking forward, that
Every
makes a
time.
lot of sense. Just the notes may not be enough.
Yes, true.
And I think when you call up the pathologist and tell the pathologist, their interest also improve, the communication
Yes.
improves, and probably the results, the outcome improves. That's what I always feel. So I make sure I always communicate with the radiologist before the procedure and with the pathologist after the procedure if you're not doing a rose. So that's an important message that communication is the essential part of our procedure. So we need to make sure we communicate well with the pathologist, and that makes a lot of sense. What do you say, Dr. Sharada?
Yes, sir, that I completely agree. Communication with the pathologist will actually enhance the diagnostic yield, and then it helps us in giving a
So
proper.
we have picked up quite a few cases just because we communicated well with our pathologist and our microbiologist. What are we expecting? What are we looking forward? That increases the interest, and they just specifically look for that, and that improves your diagnosis. So I think that's important.
Another point I would like to say with regard to this one is like if the patient already has a diagnosis, even that also has to be communicated to the pathologist. Suppose the
Yes.
patient already is a diagnosed case of adenocarcinoma, and then the material now is taken, the EBUS is done mainly for molecular testing. Even that also has to be communicated so that the pathologist will not do additional immunomarkers because the diagnosis is already established and all the material can be sent for molecular testing.
Okay, thank you. That's an important message.
I have a question. I just want your opinion regarding this because I had this problem when I was doing a saline sample. I usually used to do only one or two, either it's one or two passes in the saline sample. So what I've seen is the chances of getting a gene expert positivity drastically decreases if you use one sample. That's what I have seen in my practice. So now I started doing more passes in the saline sample if you really want to get a good gene expert positive. I just want to know your experience regarding that.
So normally, if I am suspecting TB, I would do at least two. And maybe even the last flush of the needle, I would put it in saline after taking a sample for my the core. If I've already taken in formalin or the fixator, I would still use 2 passes. We send it for in saline, and the last flush of this of the needle after each pass. That's what we do. So that if you're suspecting TB, definitely a good sample is very, very essential. And we have got gene expert positive. In many cases, gene expert positive granulomas seen, but cultures negative. We have seen situations like that. So that when you have a doubt between sarcoid and TB, and if your gene expert is positive, it helps you a lot. So that's what we are.
Even my yield of culture positivity is very, very low. Especially for tuberculosis, culture positivity is very low. But what I've seen is the gene expert positivity drastically increases if you do 2 passes rather than 1 pass.
I agree with that.
This is my own personal experience. This is what I have
Dr. Supreet, you want to say something?
Yes, sir. What you said is right, because it has to be. Because this extrapulmonary tuberculosis is a paucibacillary disease. So whenever, if you see the literature, like the guidelines say, only if you do normal culture also extrapulmonary tuberculosis, the positivity of culture is only 50%. So that we can expect. But once we get a granuloma or AFB stain or gene expert positive or necrosis, our diagnosis tend to be tuberculosis. And in case of sarcoidosis, as we discussed, we must combine with transbronchial and endobronchial biopsy to improve our yield of sarcoidosis.
Yes.
This was my next question: is how many of us, if you're suspecting sarcoidosis and the TBNA, the first thing is sarcoidosis, how many of us change over and do an endobronchial biopsy?
We do all 3.
We do all 3: endobronchial, transbronchial, and lymph node. All 3.
All 3.
No, even if you are using
if the mucosa is normal, I would still like to do it. Even
because when conventional, definitely, even with an EBUS, you're again doing the others.
So if you are suspecting sarcoid, endobronchial, transbronchial, and TBNA,
even if
I would always send for gene expert and culture for that. So that a lot of times there is a confusion between sarcoid and TB. There's always a problem there. So gene expert, if comes positive, that it helps you a lot.
So even if the parenchyma is normal, we must combine with TBLB and EBLB.
Okay. Thank you. I think we are now moving towards the last question of today's talk. Dr. Supreet, this is again a question for you. What is the future direction to improve EBUS yield? Technology, training, or both?
I will say both. Technology in the sense, we need to have a lot of now AI and also cytopathology available. So if we can get an expert opinion by the side, and technology in this, and other was technology and technique. Technique, obviously we need to improvise our technique, and we know we are getting towards intranodal forceps biopsy, cryobiopsy. Definitely we need to be acquainted with those techniques and improve our yield, because rebiopsy or rebus is a very difficult task, and always having a luxury if the pathologist is available. That's a luxury.
I think we have covered most of the questions now. Any specific questions or inputs from any of the panelists? Please, I would love to hear from you.
The needle, what we discussed about that 19 gauge and 25 gauge at all. So 19, I think it stopped because of the bloody material and low positivity. But the good thing about 19 and 25 is you get greater maneuverability. The scope can be maneuvered very good. So if you have a forward of like 60% with the 21, 22 gauge, if you have a 25 gauge or 19 gauge, that goes up to 120. So so in the case of 4L, 10L, like hilar nodes, 11L or 11R, you have a greater maneuverability with 19 gauge and 25 gauge as compared to 22 gauge.
Agree.
Now, the problem with this is because when I started with blind TBNA, and during those days we used to use 19 gauge for blind TBNA. So I have done that. So I am very comfortable with this also. So maybe that must be one of my biases. But then yes, we are now 19 gauge is no longer available. I think it's not available, and it gives a little more bloodier tissue. But initial days we used to think that because our micropathologists cytopathologists are not so well trained, they used to ask for bigger tissue tissue. That's why we used to use 19 gauge. But I think more or less now we all have moved to 21 or 22 gauge needles, and we have stopped using 19 gauge. Yes,
And
Dr.
sir,
Bala?
one more thing is that we were talking about cough. And a conventional TBNA, we used to say patient to cough because there's a 3 techniques, jab and technique. So we used to say cough also. So that is one of the techniques for getting a TBNA in a blind TBNA, I'm telling. That is one of the techniques. But now we know EBUS, so we are very much scared. We just withdraw it. But
I was trained for doing blind TBNA, so it's okay for me to EBUS TBNA with 19. I used to do it, but now we also have stopped using 19 gauge. We all have shifted to 21 or 20 gauge. Yes, 21 or 22 gauge. Yeah.
The one point what we missed in this lecture is probably the Vijay has pointed out. One is the Procore needle and the Francine tip needles. These 2 needles, I think we have missed in the discussion.
Yeah.
So I don't know who's using a Procore needle as of now. Probably once the internal cryobiopsy has come, all these Procore needles and the Francine tip needles, that's a Boston acquired needle. Probably many people started using less.
I have used them. I have used both, but didn't found any extra advantage.
Exactly. Even the guidelines and the publications do tell the same thing. It doesn't increase the diagnostic yield very, very high compared to a routine 22 gauge or a 21 gauge needles. Probably what they've seen is the architectural deformity is much lesser in the Procore and in the Francine tip needles compared to the regular EBUS TBNA needles. But the cost is dramatically increases. The cost is 3 times the cost of the regular EBUS needle. That's what I feel.
But in real world, I've not found any difference in my diagnosis. And I have used them, and I somehow is much more comfortable with your 21 or 22 Olympus needles. And that's what they have done very well, and they have stood the test of time. All the other needles which have came and never really taken off very well. So I would say, and with the cryo coming in, now people are gradually shifting to cryo. If your normal TBNA is not doing well, you're not getting an answer, switch to cryo.
I think the next is directly to the cryo, not to change the needle. That's what I have seen in my practice.
And as you rightly said, it adds a lot of cost. That's if you use these newer needles, it adds a lot of cost to the procedure. Anything else?
I would like to
please
add the last comment. So I always view ROSE as a win-win situation because I'm a pulmonary pathologist. So I get an opportunity to communicate with the clinician about the clinical details of the patient, and at the same time, I get an opportunity to triage the sample adequately. But this is not possible in all the institutes because the pathologists, they don't just see only the lung. They report the other systems as well. So in such situations, the pathologists may not be in a position to spare time for this procedure. So in such situations, the pulmonologist should always communicate with the pathologist and then work up a standardized protocol, specific protocol for the institute. Communicate with them, and then either the cytotechnologist can be trained, or the pulmonologists themselves can be trained from the pathologist, or only in certain scenarios the pathologist can be called to do the ROSE. I mean, the protocol has to be worked up.
I agree with you because most of the pathologists are not well trained for EBUS TBNA. I remember Dr. Anita Burgess, I had a chance to send samples to her, and she used to always say, send bigger tissues. She was always like, why are you sending so small tissues? So it was very difficult in early days, but then over a period of time, we started because they're used to seeing larger tissues. They were not used to see the smaller tissues, though she was very good in her histopathology. But then for EBUS TBNA, I had a struggle with her for almost a year before we started getting good answers, because I used to send good sample to her and she said the negative, that we don't have send more tissue, it's inadequate sample, please repeat. So at least a year I was struggling with her, and then we were able to, and even I think Dr. Murthy at Global, I think I don't remember her full name. Both of them I struggled for 1 year before we really started getting a positive answer. So my needle used to be in the lymph node, but then they were giving a negative answer for me. So gradually we tried to communicate with them and build up, and then took them into confidence, and then we were able to achieve that. So it's a communication which matters a lot, and gradually we can grow together. That's what it looks like to me. Any other comments from any of the panelists?
Sir, I'll just add to what. Yeah.
You continue.
Yeah. So I'll just add what everybody is. Just don't keep all these procedures in between your OPRs. I know it is very busy OPs, and you do in between, do some EBUS, come back. So that while doing procedure, your mind is in OPD. So don't do that. Second, keep good coordination with your team, with your technicians, with your pathologist, or with your colleagues and juniors to improve the yield, and for the pre-procedure preparation and post-procedure monitoring, because post-procedure you are not there, your team is handling the patient. Third again, most important is preserving the extra sample. If you are struggling with the diagnosis, call up a pathologist or a microbiologist and tell them to preserve the sample if you need extra sampling for either molecular or some extra microbiological testing.
Thank you. That's a nice summary. Thank you. Dr. Vrushali.
So I was just, we just said, you said that the needle was inside the node, but still, they were having a tough job finding up. So is this got something to do with, using the stylet without using or not using a stylet? So just a word from each of you all. So that if you use a stylet while entering and then, you have a gradual pull out or a capillary pull or this, will that prevent the bronchial epithelial cells from just spoiling your sample? A question for everyone, actually.
I think I always use a stylet and then clean the tip with while juggling the stylet a little bit, remove the stylet, put the suction, and then before removing and again do the juggling of the needle, and then stop the suction, remove the needle. And that's a standard way we practice, and we are doing fine. We have a very decent, I think gradually you build up and you understand how to do the EBUS TBNA, and it's a learning curve. And your results initially are always a little lesser than what you gradually build up, and you keep on auditing yourself, trying to figure out what is the best option for you. And it works wonderfully well, and you have to develop your own strategy in your individual case scenario, in your individual situation. So anything you want to add, Dr. Bala Raju?
Yeah, I think you touched the main point, because one point what I have learned is to cut the suction when the needle is inside the lymph node.
Yes.
So that what it really prevents the bronchial epithelium's contamination going inside the needle. This is what I have learned.
So always stop the suction and use minimal suction. That's what I have done. So we see that we don't, once we have done the juggling of the needle in the lymph node, we stop the suction and remove the needle.
Pulling it out. Yes.
Yeah, that's what we always do, and that's the standard way of practice. Because if you use too much suction, then you can also get a bloody sample. That's another problem. So I think we close the session of today.
Yeah.
Dr. Supreet, anything you want to add today?
No, nothing, sir. Everything is done. But the only thing is, last point, why was suction versus no suction?
No data. I think the studies have not shown that any of them is beneficial. So it's your individual practice which matters. And some people use it, some people don't, but the trials have not shown any benefit of either of them.
And so the studies are not for the diagnostic yield, but they are for if you require more sample, then you can use a suction. But diagnosis-wise, there's no difference between a suction or
that's what we are looking for. That's the final thing.
This was just to complete the webinar. And the thing is, always I want to always ask for cell block, because whenever I had a discussion with pathology, you also say we'll do cell block, you give more sample, cytospin. So that's what we always discuss, have a good relationship, but we call it CRP, clinical, radiological, and pathological correlation. So we discuss with radiologists, even for my bronchoscopies also, I go and see the CT scan, which lobe, which segment, and that's how increases my yield of bronchoscopy rather than roaming here and there.
Yes.
And similarly, for CT also, we map the node and discuss with what is the prevalence probability with the radiologist, and then after sampling, we discuss with the pathologist also. So he's more focused on that. So that
and you give a feedback back to the radiologist that this is what it is.
Then we tell the radiologist.
You have to make them your friends. Yeah, you have to make them your friends. You have to be working together.
Yeah, you have to discuss either for every ILD, anything like we discuss with radiologists is very, and pathologist is utmost importance.
Yeah, you, Dr.
When
There are very
anesthesiologist
few.
should be or
There
the
are
best
very few
should be-
thoracic pathologists are there. So I would like to congratulate Madam. Like she is doing only thoracic pathology. That is very less people are practicing thoracic pathology.
Yes, hats off to her. Yeah, hats off, Dr. Sharada. Thank you
so
for
much.
being a thoracic pathologist.
Yeah.
And Dr. Pravin, you want to add something?
Yeah, I just wanted to say in early days I was struggling with anesthesiologists because you need to make sure you are good friends with anesthesiologists because they are in hurry with other procedures. So so they are always in hurry. They are like, how many passes more, how many passes more? And I used to tell them we are at high stakes. We need minimum 4 passes each node. So make sure you are a good friend of anesthesiologists.
And one more thing is always get cardiac clearance.
for history of if
Because I had a bad patient who got VT while doing a EBUS.
yeah, that you can make institutional protocol. So in my training institutes, more than 50 years of age, you always get 2D echo and get cardiac clearance if there is
My
something.
anesthetist was refused to do anesthesia for patient who is more than 50, and they will always ask, especially if you are going for EBUS, they ask for a cardiac clearance and echo.
Yes, sir.
That's what, though guidelines may or may not say it, but that's what
But we have to get, sir, because I have seen, and I am saying on a forum, I have seen a death of EBUS with my patient, diagnostic EBUS.
So accepting the mistakes and then growing from it, that's very important.
Because I'll just discuss, because that patient was malignancy and it was having a non-STEMI. So the cardiologist told, if I do a cath for him, then you can't do procedure because it'll be on double platelets. So right now he's in stable state, you do a biopsy. So we took him for EBUS and we finished the EBUS within 15 minutes. But the thing is, while taking out from anesthesia, I developed VT. And then he was intubated and then he's come to death. So it's really a bad, that's what I'm saying. Cardiac is very, very important. Be clear about cardiac before doing EBUS, because since you are our team, I do usually under GA LMA. All my cases to be on safer side and anesthetist by the side.
Right.
That's individual practice in individual institutions. We usually do under conscious sedation.
Without LMA or ET. Yeah, either this.
Thank you. I think we now close today's session.
Yeah.
Thanks to all the panelists.
Thank
Dr.
you for having us.
Dr. Vrushali, Dr. Pravin, Dr. Sharada, and Dr. Supreet. Thanks to all of you.
Thank you, sir.
Thanks
Thank you,
CCI
sir.
for this wonderful opportunity. Now we hope that we have given some good insight to all our viewers that how to improve the yield on your EBUS TBNA and how we can make ourselves better. Thank you. I close the session for today.
Thank you. Thank you for
Thank you.